For your next cataract procedure, you're invited to the ultimate experience of control and clarity. The Clarion IOL with the Autonomy Delivery System. Autonomy is the first and only automated, disposable preloaded IOL delivery system. With its innovative CO2-powered delivery mechanism, Autonomy brings the predictable precision of automation to every delivery of the Clarion aspheric IOL. The device takes just 3 steps to prepare. Fill the device with an Alcon-qualified viscoelastic. Remove the lockout assembly and use your thumb to advance the plunger and fold the IOL up to the pause location. Once the lens is in the pause location, confirm that the lens is properly folded and deliver it within 1 minute. The ergonomic design fits comfortably in your hand for intuitive control of the device during delivery, while the responsive speed control lever enables easy, single-handed control of IOL advancement. With its proprietary depth guard, Autonomy protects incisions as small as 2.2 millimeters. During delivery, you can vary the plunger speed at any time by adjusting the pressure on the speed control lever. Simply press the lever with your index finger to advance the plunger and deliver the IOL, ensuring that the leading haptic is properly placed within the eye as you implant the lens. It's that easy to deliver the Clarion IOL, a lens with a new hydrophobic acrylic biomaterial of unsurpassed clarity. Built with the exceptional bio-optics and biomechanics of Alcon IOLs, Clarion features an advanced IOL design with a fully usable 6mm aspheric optic dedicated to sharp, crisp vision from edge to edge. Produced with an advanced manufacturing process, Clarion also features a precision edge design. This design includes a proprietary edge curvature that reduces edge glare, as well as a continuous posterior barrier that guards against PCO and minimizes ND-YAG procedures. Stable force haptics give Clarion exceptional axial stability across a range of capsule sizes, with minimal axial shift and maximum refractive predictability. With its ultra-smooth optic, Clarion delivers unsurpassed clarity from the start, with among the lowest level of surface haze. And with its new microvacuole-resistant hydrophobic acrylic biomaterial, Clarion delivers unsurpassed clarity that lasts. This is a truly pristine premium IOL, delivered with easy, intuitive control. Together, Clarion Autonomy is the ultimate IOL delivery experience.
In 1976, a picture from outer space sparked the world's imagination. NASA's Viking 1 sent an image of what appeared to be a human face on the surface of Mars. The story took on mythical proportions. Many took it as proof that alien life existed. But it would be decades before improved technology would let them take a better picture. Innovative technology like 3D visualization can help you see reality and transform your surgical experience. Discover the wonders of 3D visualization technology. From Mars to your operating room. It's time to take another look.
Welcome to the Alcon Experience Academy, your one-stop resource for training, product information, and much more. The Alcon Experience Academy is a great resource for any healthcare professional who engages with the eye, including ophthalmologists, optometrists, nurses, technicians, and students. If staying up to date on products, services, techniques, and training taught by professionals from around the world is important to you, the Alcon Experience Academy should be your go-to source. Let's take a look. This scrolling banner will immediately let you know what's new. Content of interest can be customized by you to show the latest content based on your personal preferences, whether by an area of focus or by specific topics of interest. This engaging content comes from some of the leading specialists from around the world. Recently added content will show the newest resources added to the site, allowing you to explore some of the latest innovations in eye care. My Courses is where you will find courses for your specific needs. It also shows the courses you have taken and completed and those courses you are still in the process of completing. In addition to other helpful tools, additional resources will point you to more than 100 informative FAQ videos on Alcon technology. My Events shows you a calendar of the upcoming webinars or face-to-face training events that you've signed up to attend. Now let's take a look at some features of the Alcon Experience Academy. Accessibility. Gain access to the content you need when you need it. The mobile-friendly format allows you to access content on the go. Usability. Ease of use on every step of your informational journey. Navigation. Move easily from one topic to the next, from one piece of content to the next. Searchability. Find what you need fast. Trackability. Keep track of the modules you've completed, ones you still need to complete, and exactly where you are in the modules you've started. Robust content. Over 500 training videos, with additional content being added all the time. Getting started is easy. Simply register at alconexperienceacademy.com and gain access to all of this content today.
Ingenuity Visualization System with Constellation Vision System. Designed to help the surgeon improve the outcomes of vitreoretinal and combined surgeries. Constellation enables surgeons to maintain IOP to plus or minus 2 millimeters of mercury. Dual pneumatic drive technology. High-speed beveled vitrectomy probes, up to 20,000 cuts per minute. Finesse shark skin ILM forceps with microstructured forceps tip. An enhanced 27-gauge grasping platform. Automated fluid air exchange. Embedded PurePoint laser with vector articulating illuminated laser probes in 27-gauge and xenon illumination. Ozil torsional phacoemulsification. Integration with Ingenuity 3D visualization system. Up to 5 times extended depth of field to maintain sharp focus. Up to 48% increased magnification to amplify the surgical view. Up to 42% increased depth resolution to resolve fine details. Data Fusion Integrated Surgical Platform. Monitor real-time IOP, flow rate, cutting speed, and other surgical parameters. Operate Ingenuity through Constellation. Integrated image profiles in the Constellation procedural workflow. Coming soon. Alcon's visualization innovation, Engenuity 1.4. Easy access to all Engenuity system benefits. Centralized data fusion experience connecting Alcon surgical devices, phaco, retina, and diagnostics with the Engenuity system. Individualized image optimization, image mode thumbnails, color temperature thumbnails.
First, there was monofocal. Then, the dawn of advanced technology IOLs. Now, in a world where patients have more options than ever before, where digital engagement is on the rise, and post-op satisfaction starts with selecting the right lens, a new education tool has arrived. The Smart Educator from Alcon. Finally, patients can see in vivid digital detail how different lenses work in real-world scenarios. It's interactive. It's convenient. And it's ready for action. Set yourself and your patients up for success with Alcon's most advanced IOL education tool ever. The Smart Educator, available now on web, iOS, and Android.
The Argos Biometer with Image Guidance by Alcon. Faster, easier, better. Argos is a smart planning solution designed to keep efficiency and accuracy flowing through your clinic. Featuring a biometry and keratometry capture time of less than 1 second. Real-time guidance from OCT imaging makes it easier to ensure you are obtaining accurate measurements at the time of capture. Advanced swept source OCT technology delivers higher acquisition rates than other OCT biometers. Argos is fully integrated with the Alcon Vision Planner, as well as the Alcon Cataract Refractive Suite, bringing you greater efficiency. The Argos Biometer with Image Guidance by Alcon is designed to streamline your planning process and help deliver better outcomes for more patients.
This is an exciting lens. It's that thing we've been looking for a while.
They have entered the field in a dramatic way with something that pretty much everything else had the water.
No es que mejoró, es que se transformó totalmente.
It made a great change in life.
I couldn't believe it. I was like, wow, I could see things I never saw before.
It would be my new go-to lens.
I would rate it 10 out of 10 in all conditions, whether it be night or day. It's just amazing.
Encantado.
Unbelievable.
Fue maravilloso.
Amazing. They've changed my life.
It's life changing.
It's the next step.
It's been a long time coming.
2, 1.
Hi, good evening, everyone. Welcome back to another season of ITV. It's been quite a while since we last saw each other. I think about 7 months to be exact. But it is nice to be back on this platform as we gear up for more events in the new season of ITV this 2023.
Indeed, there are many exciting things in store for all of us now that COVID-19 restrictions are easing up. This year, the I Envision aims to kickstart not only its flagship webinar series, ITV, but it will also introduce a face-to-face postgrad event.
Wow, I can't wait.
But before anything else, we'd like to introduce ourselves. I am Aideen Sonar.
And I am Pia Texon Diaz, and we will welcome you to episode 23 of ITV. But before that, a little background. So today's episode is the final part of the Alcon Impact Program. In our previous series, we went through the steps involved in exploring the new technology brought about by Alcon. So the Alcon Toric IOLs, to be exact. Let's give everyone a quick recap of our previous episodes from the Alcon Impact Program.
In episode 1, we discussed not just why toric IOLs are so special, but why toric IOL implantation is quite different. We explored this with our big boss, Dr. Victor Caparas, and one of our TMC alumni, Dr. Keisha Lennon.
In episode 2, we explored how exactly do we implant toric IOLs with cornea, refractive, and laser surgery specialist Dr. Elisa Yu Mateo. Then, we dove into the questions. How do you maximize the ocular surface? Are marker machines necessary? And even, what is the proper patient positioning?
With this in mind, we thus move to today's topic where we explore the first-hand experiences of those who underwent training with the Alcon Impact Program themselves.
So today, we welcome you to ITV episode 23, The Truth Behind Toric, Experiences and Discoveries.
Here, our recent alumni will share first-hand insights in how toric IOLs have become a viable option in treating their cataract patients.
But before we go any further, we'd like to introduce Mr. Samrat Joshi, the Commercial Head and Country Manager of Alcon Laboratories Incorporated, for his opening remarks.
Hello everyone, greetings from Alcon. Welcome to 23rd ITV series from Medical City Eye Institute. Alcon Philippines is thankful to the Eye Institute for the trust and confidence in our team. And under the leadership of Dr. Victor Capras, an immense support coming from the senior ophthalmologists in the department to take the astigmatism management to the next level. We are so happy to see the outcome of the program, and the members enrolled into this program are so confident of using the toric lenses in their cataract surgeries. Once again, thanks for the opportunity given to Alcon Philippines, and all the best for the ITV program.
Okay. Thank you, Mr. Joshi, for that warm welcome, and thank you also to Alcon for partnering with us to bring these innovations to the forefront this 2023. Today, we will discuss the three-part clinical preparations needed in implanting a toric IOL. We will look at the details of pre-op calculations, insights on intra-op techniques, and considerations for post-op monitoring.
So for our first segment, we will look at preoperative considerations with Dr. Keisha Lennon. So Dr. Lennon is a graduate of the Ateneo School of Medicine and Public Health. She finished her residency as well as her fellowship training in cornea, external disease, and refractive surgery at the Medical City. She is also a member of the Philippine Cornea Society and is an active consultant in the medical city where she not only practices her subspecialty but is also currently a part of the residence training committee.
Dr. Keisha is also one of the pioneer members of the Alcon Impact program, where she was one of the first to explore toric IOLs for her cataract patients. So without further ado, let us welcome our first speaker for today, Dr. Akisha De Yonko Lennon.
Okay, so good afternoon to everyone. It's nice to be here again and be one of the speakers for the Alcon Impact program. So today I will be giving some practical tips for preoperative considerations for toric IOL implantation. And again, it's basically a review of what we have tackled in the previous episodes. But I have now added a case, which I have done just recently, to illustrate the learning points even further. Okay, so I've organized this lecture again into 5 key areas for preoperative screening. And again, I just like you to remember this image. I think growing up, we've seen this particular device and this particular brand called Think Smart. So, when performing refractive cataract surgery, I personally find this mnemonic very useful because it guides me in my preoperative assessment. And it also provides me with the right mindset that is highly required when you do refractive cataract surgery. So, it's a bit different nowadays because a lot of our patients are actually seeking presbyopic correction. So, these patients are highly demanding, and as the surgeon, you're supposed to not only remove the cataract but also to provide them with the type of vision that will allow them to perform majority of their daily activities. Okay. All right. So I'll go through the key steps in preoperative assessment by showing this case of a 62-year-old male who was actually referred to me for cataract surgery by a previous patient that I've done. And this patient was particularly seeking presbyopic correction. So, to plan for your refractive cataract surgery, it's highly important, like when we do what we do in LASIK screening, that you get to know your patient. You have to know their activities. For example, you have to ask them if they're driving. And when you ask them about driving, you have to know if they also drive at night. Because driving at night will be more significantly challenging because of the increase in our spherical aberrations. Also, you have to know if the patient likes to read and also likes to do a lot of near activities. So, as for my patient, this patient was very particular about driving and also about computer use because it's also still related to his work. So, a lot of patients, despite being 60 years old, continue to go to offices, and that's the main difference that we observe comparing the patients that we've seen in previous years. So, the manifest refraction of your patient will also give you a clue as to the patient's demands and motivation. So, if a patient came to you and this patient is highly myopic, so you'd expect that this patient will require excellent, at least excellent reading. But for a hyperopic patient, as you can see here in this case, this patient was really highly motivated just to get that extra reading ability for computer work. So he's not talking about giving him excellent reading at 40 cm or even near, but he just really wants to be able to see his computer screen clearly. So his demands was basically for distance and also for intermediate vision. So my plan for this patient was to give him the Alcon Vivity IOL, which provides exactly that. It gives you this extended vision from distance until intermediate. Okay. So after history taking and visual acuity, I usually perform an assessment of the ocular surface. And I really like to start my exam with this. So even before I take a look at the eye using the slit lamp, I automatically put the fluorescein dye. I just don't want to shine light over the eye and to change the ocular surface by stimulating the reflex tearing. So I usually put a dye and I automatically check for the tear film. So I like to start with this because again, it gives me the opportunity to tell the patient up front if I need to treat the ocular surface first before I send him um, uh, for diagnostic testing. So what I usually do is that when I see a patient in the clinic and this patient has a dry eye, I treat him for at least 4 weeks. If the patient is amenable to that and he's not in a hurry, and then I ask the patient to come back, and that's the time that I give him clearance to have the test done, particularly the biometry. But the rest of the exams, which are not reflective technologies, you can actually have the patient go through those already. So again, it's important to have an accurate biometry because your IOL calculation is one of the keys to a successful refractive outcome. So again, just very briefly, we can't really overemphasize the importance of the ocular surface in toric IOL implantation. So it's important to know, and I'm bringing the slide again, just to drive the point that the air tear interface is really the first refractive medium encountered by the light entering the eye. So patients with dry eyes do present with fluctuations in quantity and quality of vision. And similarly, you'll also notice that this will affect the precision of your measurements when you do your keratometry assessments in your biometry. In fact, if you notice, let's go here, next slide. In fact, several studies have actually showed that more than 50% of our patients who demand cataract surgery actually have ocular surface irregularities. So it's nice to incorporate this already in your practice if you're planning to do more refractive cataract surgeries. Okay. Okay. Again, so this is again another table that I like to show because it gives you an idea about how these devices or biometers used in clinical practice work now. So if you notice, all except the Pentacam AXL use automated keratometry for the K assessment. So more specifically, these machines will rely on your light reflections of the tear film. So any changes in the tear film will definitely influence your anterior corneal measurements. And if you're planning to use a toric lens, if you use a K measurement on a patient with dry eye, then it will definitely give you, you will definitely miss your refractive target. So for this patient, I noted that he had decreased wettability dry eye. So I pre-treated him for at least 4 weeks using diclofosol and sodium hyaluronate. And then I saw him again 4 weeks after. And when the dry eye has already been treated, I gave him a request for ocular biometry. Now, the next is to measure your corneal astigmatism in terms of meridian and magnitude. And this can be done by ordering your biometry. So, accurate measurements of these two things actually will increase the likelihood of an excellent outcome post toric implantation. So the device you select to measure your corneal astigmatism highly matters. So if you notice here in this slide, those highlighted in blue, your manual keratometry, automated keratometry, your corneal topography, all can measure the anterior corneal astigmatism. But however, if you have access to a corneal tomography machine, this will also be able to measure your posterior corneal astigmatism in addition to your anterior corneal astigmatism. So if I bring back the topic of ocular biometers, if you have access to the IOL Master 700, this technology combines reflective technology plus SSOCT, then you will have a measurement of your posterior corneal astigmatism, and they reflect this in the true K or TK values. For the Scheimpflug based imaging, if you have an access to the pentacam biometry machine, then that's also one thing that you'd like to order for patients that you plan to put a toric IOL in. Okay, so when in doubt, you can always validate the key values that you get from a regular ocular biometer against a corneal topography or tomography device. So again, these are the acceptable differences. A difference in magnitude of less than zero point 0.5 diopters and a difference in meridian of less than 10 degrees are generally acceptable. So ideally, the patient should have a regular symmetric astigmatism, but this is really an ideal scenario. No, however, it can happen that you have a patient who doesn't have a symmetric astigmatism, but if you've treated the ocular surface and the patient presents with an asymmetric bow tie in your corneal topography, then that's still acceptable as long as you're sure that you've treated the ocular surface and the key values are within the acceptable differences for magnitude and meridian. Okay. In general, we'd like to avoid implanting toric lenses for corneas that have irregular astigmatism. If you're planning to start out, largely asymmetric astigmatism and skewed radial axis. Okay. So as you can see, for this particular patient, I just showed his left eye to illustrate the points further. When the biometry came out, I noticed that the left eye had an oblique astigmatism of 0.5. So without the knowledge of toric IOL implantation, I would have um, ordered a non-toric lens. However, upon reading about it, I noted that if a patient has oblique astigmatism and this measurement is from a cornea that has already been pre-treated for dry eye, I I I I was able to learn that if a patient has oblique astigmatism, this is actually is something that you should correct. So, what is a good practice, for those who want to implant toric IOL? So, for oblique astigmatism, if you're not sure, and if you're asking yourself if a toric IOL is needed, it's always good practice to just use a toric calculator for all of your cases. So whether or not the astigmatism is less than 0.75, you try to input the parameters in a toric calculator, and if it shows there that you need a toric lens, then um, and then you consider that suggestion. But the toric calculators will also point out if you don't need a toric lens. So it's a win-win situation for you. So for this case, I was advised also by one of our senior mentors to try to use a toric calculator. Okay, so showing the next slide, for this particular case, I chose to use the Barrett toric calculator because the patient didn't have any prior refractive surgery, so I really didn't need the Barrett True K. So this is the Barrett toric calculator printout for my patient. I just like to highlight a few things. No? So when using the Barrett True K calculator, it's Barrett toric calculator rather, it's very important that you click the radio button here on the upper right hand area. You have to click negative cylinder so that the target refraction shown at the bottom will be in minus cylinder form. So that's easier for you to understand the target refraction. Next, you have to know your surgically induced astigmatism. If unsure, you can put a value that is commonly used by surgeons who have not had a prior experience with your toric lenses, and then based from your refractive outcomes, you adjust it accordingly. Okay, so next, because this patient had a normal cornea, I didn't have to place the measured posterior corneal astigmatism. But for example, if you had a patient who had prior refractive surgery, it's highly recommended that you get the measured PCA, or posterior corneal astigmatism, and you input that into the machine. So for this one, I just used the population-based predicted PCA that is incorporated in Barrett. So if you notice here on the lower right, the true enough for this patient with oblique astigmatism, a toric IOL was actually recommended. So it's a T2, and again, I just wanted to point this out. The T2 has an equivalent of one cylinder in the IOL plane. But when you transpose this to the corneal plane, it actually will just deliver a 0.68 diopter of astigmatic correction. So it's nice to look at that as well. So for this patient, because he was very adamant in still being able to see his laptop after the surgery, I decided to implant a target IOL power that will give him a refraction at least closest to the first minus. So instead of a 22, I selected a 22.5 with a T2 toric power. So next up is A, which stands for alignment and centration. So just to go through this again, the accurate alignment and centration of your toric IOLs actually determines the refractive outcome. So you have a poor alignment, the patient will experience induced astigmatism, a reduction in the magnitude of correction, also will result in unwanted higher order aberrations. And all of these things will decrease the quality of vision. So it increases the chances that you'll have an unhappy patient. So one way of predicting IOL centration and alignment is to measure the angle alpha. So I know that not all centers have the eye trace, which will measure your angle alpha. So it's okay, but since if you do practice in the medical city, you're fortunate enough to have this device at the LASIK center. So if you want to enhance your refractive outcomes, you can try ordering this for your patients. Okay, so displayed here are the range of values that you will get, and any value that's higher than 0.5 millimeters is not ideal for premium IOL implantation because of potential problems in centration. So I just like to review this again. Here is a patient with against the rule corneal astigmatism, where the steep meridian is lined horizontally. So that is for your against the rule astigmatism. So note that if you implant a toric IOL, the 3 dots that you see on the IOL will be aligned on your steep meridian. Okay. So this is represented by the 3 dots in the diagram. However, the toric power of the IOL is actually 90 degrees away, and this is represented by the red line. Okay, so if a patient has a high angle alpha, the visual center, which is represented by the red crosshair there in the middle of the image, is highly misaligned with the power axis of the toric lens. So as you can see, the power axis, which is represented by the red vertical line, is not aligned with the red crosshair, which is the patient's visual axis. And you can see this in your Purkinje images when you look at the eye in the microscope. Okay, so this not only will result to poor correction of astigmatism, but it will also induce your coma, which is a type of higher order aberration. Okay, so if you have a patient planning to get a toric lens, and the patient has against the rule astigmatism and also oblique astigmatism, then you might want to consider ordering an eye trace if you have access to it. Okay. All right. So for this patient, I was able to order the eye trace, and this was his result. So as you can see, his angle alpha was 0.352, which is within the normal range. Another clue for me that the measurements that I have in my biometry is accurate is that when the trace refraction, when the eye trace provides you a trace refraction, you'll notice there the axis of the astigmatism. So my steep axis in the cornea is actually 90 degrees away to the provided axis of the patient's astigmatism here in the refraction. So this minus 0.62 diopters at 67 is equivalent to the result that I got from my pentacam biometry. So this encouraged me further to go for the toric vivity lens. Okay. So moving further, and we're ending now our checklist. R stands for retina in retina and nerve evaluation. So you have to understand that when you implant the toric lens, it's not as it's more expensive than your regular monofocal, and even more if you're planning to use a multifocal toric lens. So this is still considered a premium lens. So it's highly important that these patients that you select will have normal eyes without any macular or optic nerve pathology. But of course, there are special considerations nowadays, and I think you can go further into those specific populations when you've already implanted a lot of toric lenses in normal eyes. Okay. So for this patient, I was able to order as well a macular OCT, which I like to do for my premium patients because I just want to make sure that they're happy after the surgery. This patient had a normal macular OCT. Okay, so finally, T stands for chair time. So this may be the last, but it's actually the most important part in your preoperative assessment. So as in laser refractive surgery, you generally want to avoid perfectionists with unrealistic demands because again, we've been taught it's always nice to under promise and then over deliver. Okay, so I also like to tell the patient that the goal of the surgery is basically not to eliminate all of his refractive error, but I always tell them that the goal is to try to maximally reduce the refractive error that they have. Also, it's nice to open up to patients a little bit of information about the lens technology. So do take time explaining to them what the lens has been tested to offer. So for the Vivity lens, I told them that it really was not designed to provide you with a perfectly near vision that's very, very close. So once the patient understands that, then you can go ahead and offer this lens. Also, for toric lenses, also important to inform them that the lenses will be implanted in their eye in a particular orientation. So you have to inform them the importance of not rubbing their eyes to avoid unnecessary IOL rotation. And also, it's also good practice to inform them that in the event that you do have to do a lens rotation intra-op to rotate the lens back to its intended axis, then that's also a possibility. Okay, so just like to show the result of this patient. So here's a photo of his left eye taken at 4 weeks post-op, and you can see here beautifully the Alcon Vivity IOL. So it's right centered on the patient's visual axis. So that explains also the good visual outcomes of this patient. And if you take a look at the AR of the patient, the refraction is plano with 0 cylinder, and this was confirmed through manifest refraction. So this patient was very happy. He had uncorrected visual acuity of 20/20 and J2. So surprisingly, he was able to read until J2. Okay, so again, I'd like to end this particular lecture with this quote. The best way to get started with your toric IOLs is really to set yourself up for early success. And if you've watched our previous episodes and really applied some of the points that were discussed, I hope that your toric IOL experience will be a pleasant one. Okay. Thank you very much.
Thank you for that informative discussion, Doc Kish. Is it just me, Doc I, or does she have a real gift for making difficult concepts much easier to understand?
I super agree, Pia. Keisha really has a way of making things more digestible. She really is perfect for these types of episodes of ITV. It makes me feel like I can do Toric myself.
Yes, Doc Kish has always inspired me. I'm glad you feel that way, Doc I. Honestly, that is really the end goal of the Alcon Impact program to get everyone to feel that toric IOLs are a viable option for their practice and that no matter how long they have been practicing and no matter what specialty, they can do it too.
I really appreciate it that we have episodes like this that expose us to these new technologies.
Speaking of someone who has been unafraid to venture into innovation, we have Dr. Glenn Angeles up next. He himself has had a few years of experience with toric lenses as he was one of the first trainees under the Alcon Impact program and has been consistently using this for his current practice.
Dr. Glenn finished his medical education at the University of Santo Tomas, then ventured on to do residency in the medical city. As a testament to his drive for learning new technologies, he also has two additional master degrees under his belt, a master's in business administration and health and another for Master of Science in Innovation and Business.
I have heard that Doc Glenn brings the same drive into learning different tricks for his ORs.
Truly, with this, Dr. Glenn brings to this episode of ITV much needed pearls of wisdom for those of us still trying to figure out toric IOL implantation.
Dr. Glenn will sure share with us some of his tips and tricks that he has learned along the way to guide those still new at toric IOLs and also to give a fresh insight to those who have already begun exploring with this new lens.
This is getting more exciting, so let us not delay this any longer and let us welcome our second speaker, Dr. Glenn Angeles.
Hi, good afternoon, everyone. Thank you for the introduction, Pia and Eileen. So let me share my slides. Okay, can everyone see my slide now? So a few years back, just a background, a few years back, I was hesitant in using toric IOLs since I was not trained on how to use them during my residency days. But luckily, my senior consultants and Alcon invited me, I think last 2021, end of 2021, to join the Alcon Impact Program. And it equipped me with the necessary skills in implanting and aligning toric IOLs, which I can use in my phaco armamentarium. So patients nowadays have heightened expectations on cataract surgery. So we need to optimize surgical outcomes since the advancement of technology allowed us to offer better outcomes to our patients. So I usually offer toric lens implantation to patients with astigmatism of 0.75 and higher. But uh, I also recently I've been using the Barrett's toric formula for my patients to check whether or not they need toric lens implantation. So earlier, Keisha discussed about patient selection and preoperative considerations. I will now discuss the things that I have learned using toric IOLs. Usually for the OR, it's making the mark at first. So we have a slit lamp in our operating room. So I usually use an ink sterile irrigating cannula to mark the 12, 3, 6, and 9 o'clock positions while the patient is sitting upright. So marking is an important step of the procedure because it establishes a reference point when we use the digital marking system. You can also use a Toric reference marker like the one in the picture or a gauge 27 needle. Uh, so I always ask the patient to sit up to prevent cyclotorsion that can occur when marking as compared to when the patient is in a supine position. So when the patient is already lying down, I re-establish the marks to make sure they are clearly visible and darken them if necessary. Once done, I use the Callisto. So we have a Callisto in our OR. So to produce a reference image and a target axis starting before putting iodine drops on the patient. So you can always put your calculated toric sheet in front of you during surgery to always remember the markings. So, uh, and I usually make around 5 to 5.5 millimeter rexis for my patients. So I'll show you a video. This is a short video of the IOL implantation. Usually, I fill the bag with OVDs. I really fill it with OVDs. And when I insert the IOL, since I always, recently I've been using the Alcon Toric IOLs, uh, the, the haptics usually takes longer to open. So I can position uh, the the markings uh, in the usually around 10 to 15 degrees short of my final intraoperative mark. So it's easier for me to rotate it if necessary. And if you can see here, I usually clean the OVDs of the beneath the IOLs and to make sure that I'm uh, in the final mark of my axis. So this, as you can see, we're filling it up with uh, filling up the eye, and uh, the final rotation. It's just a short movement for the final marking. So this is another video. So still the same. So I clean it up, clean the cortex, then put the viscoelastic, the OVDs, fill up the bag to make sure that I have enough space to move around the toric IOL. And I usually ask the residents to turn on the marking system so I'll have an idea where to move it, where to move the markings uh, before it opens up. So here, I'm rotating it so it's easier for me to do my final alignment before the IOL opens. So here you go. It's easier for me like this. So sometimes uh, you'll overshoot a bit, but don't worry. You can just rotate. For Alcon lenses, you can just rotate the whole thing again to make sure you hit the your axis for the perfect alignment. So here, I'm hydrating the cornea to make sure you have a sealed wound and filling up the bag. There, making sure there are no leaks. And if you can see here in the video, the alignment is proper. We have a proper alignment. And this is another case. For this case, I think, for this case, this is another case wherein I was inserting the Toric IOL, but at the end, the patient's pupils is constricting. So what I did, I added uh, epinephrine to make sure that I can still see the markings. So don't be afraid. Some of the surgeons use their second instrument to see the markings after to align the markings. But this for this case, I use epinephrine to make sure that I can see the markings again. So for this, as we can see, toric IOLs can be a highly effective way to correct astigmatism during cataract surgery. And as mentioned earlier, the best practices for toric implantation is careful patient selection, thorough preoperative measurements, precise marking and alignment of the IOL during surgery, and appropriate care and monitoring. So don't be intimidated by toric IOLs. They actually are quite easy to use once you get the hang of it. With a little bit of training and practice, you'll find that toric IOLs are highly effective means of correcting astigmatism during cataract surgery. So if you're new to using toric IOLs, don't worry. With a little bit of guidance and practice, you'll be able to provide your patients with the benefit of astigmatism correction in no time. So good luck to everyone who plans to use toric IOLs. Uh, I would like to thank Alcon Impact Program for allowing me to learn how to use this. Thank you very much.
Such useful tips, Declan. I will be glad to keep those in mind as I start to explore the world of Toric.
Yeah, this is such an engaging discussion. I'm sure many will have questions for Doc Glenn after this segment. There was just so much insights during his lecture.
Agreed, Doc I. However, I do also wonder about what to expect after all my preparations and adjusted technique in the OR. I wonder what refractive outcomes I should expect after the OR and how I should also prepare my patient.
It's really very important to consider these things, especially since most doctors are still not so used to the post-op monitoring for this type of IOL.
Yes, it's actually quite timely then that we also have a segment to talk about these details. In fact, we have a speaker who has been tasked to talk specifically about all the considerations for post-op monitoring.
Our third and final speaker for today is none other than Dr. Denise Granada. Denise graduated from Iloilo Doctors College of Medicine. She then moved on to do residency here in the medical city and was chief resident from 2020 to 2021, where she was able to do quite a few cases under the Alcon Impact program.
Wow, it's so nice and exciting to see another young ophthalmologist trying out these new technologies too.
Yeah, so let's hear what this is all about. I am glad to welcome Dr. Denise Granada to talk about post-op monitoring considerations for toric patients.
So, good afternoon, everyone. Before I start my presentation, I would like to thank Alcon and the Institute for giving me this opportunity to share my experiences with toric cataract surgery, despite the very limited knowledge and the very limited number of cases I have done during my residency. And you have already heard from the last two speakers the preoperative and the intraoperative points. And just as they did, I also hope to get my message across, and this time by focusing on the postoperative considerations. So this is going to be the outline of my presentation. So what we usually have in mind as residents and beginning surgeons was to at least learn the basics of cataract surgery. And obviously, we want to do the procedure well and successfully. But then, just as anything with medicine, we should not stop there, and the learning shouldn't stop there as well. So this is the case with learning toric cataract surgery, and this is why we recommend it first for beginning surgeons and for residents. This is so because premium lenses have been an important part of modern ophthalmology and have been at their prime in the recent years. So why do we recommend it for residents? It is primarily for resident education. It is for the residents to learn the surgical technique. It is for them to know the preoperative and the postoperative management. And more importantly, it's for the residents to learn the skill of patient counseling. Other than these, it will also help us in an easier transition for private practice in the future. And it will also give our patients a wider range of choices, especially with the increasing demand in spectacle independence. So, as a resident, I was able to do this case, a 75-year-old male with controlled hypertension and diabetes. This is the ocular examination of both eyes. We noted significant cataracts for both eyes with the grading seen on the table on your screens. The fundoscopy findings were also unremarkable, so we proceeded on to advise the patient for cataract surgery and to assess the patient if he was a good candidate for toric lenses. So the patient underwent biometry of both eyes. This is the biometry of the patient for the right eye, and the intended implantation axis for this eye was at 59 degrees. As for the left eye, the intended axis was at 122 degrees with an IOL power of 17.5 with 1.5 cylinder. So this is a video of the surgery I did on the right eye. So as you can see, you see the dye markings that we did on the patient with the patient sitting upright, and then the green markers were from the Callisto system. We then proceeded on with the usual steps in cataract surgery, beginning with the intracameral anesthesia, the trypan blue dye, and the injection of the OVD. Here we then made the main incision in preparation for the capsular rhexis. At this point, we have to make sure, and it was also mentioned in the previous lecture, that we have to make a rhexis size that would actually overlap the optical rim. So that's around 5 to 5.5. And then we proceeded on with an uneventful phacoemulsification and cortical removal before again injecting OVD in preparation for IOL insertion. So the most important step for this procedure is actually the IOL insertion and the positioning. So upon injecting the IOL, we are shown the mark. We usually ask for the markers to be turned on and we allow the IOL to unfold. And then we proceed on to rotate the lens to the desired axis. But in this video, or in this case, I had a little bit of difficulty rotating the IOL to the desired axis. I had to rotate it 3 times until I was able to finally stabilize it. With these types of IOLs, you cannot rotate the IOL against its haptics, so you have to rotate it 360 degrees. And once in position, we slowly and carefully remove the OVD, especially behind the IOL. But we have to make sure as well that you keep the IOL in place and in position. Once settled, we may choose to inject carbachol to slightly constrict the pupil and stabilize the lens. And then we seal the wound and inject intracameral antibiotic. So after the surgery, we have several post-operative considerations that the surgeon and the patients should be aware of. Routinely, our patients should be aware of the post-op medications, the limitation in activity, the importance of eye protection, avoidance of infection, and the importance of follow-up. As for the surgeon, it is important also that we properly advise our patients, especially in terms of complications, the possibility of the IOL rotating away from the axis, And you have to talk to the patient as well regarding their vision satisfaction. So post-op, we usually check the patient at day 1 week post-op, and at 1 month post-op. At day 1, the VA of my patient was at 2050 for both eyes. This was attributed to the central DM folds seen on both corneas. But at 1 week post-op, as expected, we saw that the corneas cleared out and the vision improved to 20/20 - 2. For toric surgeries, it is important that we always check for the IOL alignment, and this is recommended to be done as early as 1 week after the surgery. This is to enable us to check for early misalignment and to be able the surgeon to address this misalignment early on. And then at 1 month post-op, we were not able to see any difference from the 1 week consult results. So we did dilated eye exam and slit lamp examination of both eyes. And this is the photo of the right and the left eye dilated. And as depicted by the slit beams, we see that the axis of both eyes are accurate as to the preoperative intended axis alignment. At this point, we noted that the vision, the IOL axis, and the IOL position, as well as the overall status of the eye, were all stable. So, as what I have mentioned in the case that I have presented, there are several things that we have to monitor and to look out for after the surgery, which will, of course, add to the measure of success of your procedure. Post-op, we watch out for the complications, including the most common one, which is IOL rotation and tilting. And as for the monitoring, the surgeon should do proper monitoring of the VA, the refraction, and the residual cylinder of the patient. And of course, we also have to take note of any opportunities for improvement so that this will benefit future patients. Other than watching out for the usual cataract complications such as infection, in toric cases, the most important and the most common complication would actually be IOL rotation or tilting. This is important to monitor as an off-axis lens would actually defeat your purpose of correcting the patient's astigmatism, and even in some cases, you worsen it. So this off-axis IOL causes misalignment of the astigmatic correction, thereby resulting to suboptimal visual improvement. So again, this should be recognized early in the post-op course because it will enable the surgeon to reposition the IOL in time before the capsular fibrosis occurs to achieve a more stable IOL position. In some sources, there are certain risk factors that would cause post-op IOL rotation, and they actually divided it into anatomic, intraoperative, and post-operative risk factors. Anatomically, those at risk are usually those with long axial lengths, those with high myopia, and with larger capsular bags. While intra-op, those who are at risk are those with retained OVDs, especially behind the IOL, and those with an incomplete overlap of the anterior capsular rim and the IOL optic. While post-op, we have to take note of any incision leaks, and we have to advise our patients to avoid any forms of ocular trauma and vigorous physical activity. To address these risk factors, some of the advice and the interventions offered were these are the following. So we can insert a capsular tension ring. So this is applicable for patients with large capsular bags and those who have high myopia. And then again, the rex's size for our surgery should at least be 5 to 5.5 to properly overlap the optic rim. And we have to emphasize again that OVD removal, especially behind the IOL, is important as retained OVD will really cause the lens to slightly overshoot the desired axis. And finally, we have to continue to emphasize to our patients to avoid eye rubbing or to avoid any forms of trauma and to avoid any strenuous physical activities. Outcome measurement is important as this enables, again, early detection of any complications or any cause of poor visual improvement as well as inconsistencies with the pre-op and the post-op results. It is important to ensure that alignment is properly and accurately conducted. This is to eliminate the false positives and the false negatives. The false positives meaning that the IOL is correctly aligned but it appears rotated, and false negatives meaning rotated IOL that is actually correctly aligned. So if misalignment is present and is usually unacceptable, repositioning is recommended from this study in less than 4 weeks post-op. Because again, we want to avoid the capsular fibrosis that occurs post-operatively. Also, we have to do slit lamp examination of the axis of alignment, maybe done by rotating the slit beam just as I did on my patient a while ago. This procedure of using the slit beam to check for the axis is actually effective and it is simple, but then it may be prone to errors. So as an alternative, we may actually use the wavefront aberrometer, which we actually have in TMC, which is the eye trace. We have heard much about the eye trace in the last lecture, so it is recommended to use the barometer both for pre-op and post-op monitoring, especially for us beginners and for residents as well, who may have the machine in their institution and those who have it in their practice. And then this machine, it basically maps out the eye and provides you information for a more precise IOL placement. More importantly, post-operatively, this will really be helpful for you when monitoring for the alignment of your IOL, as it gives you information of the lens position and the lens axis even without dilating the eye. I just found two studies conducted on resident cataract surgery outcomes with toric intraocular lenses. So the study on the left of the screen aimed to evaluate the effectiveness of toric intraocular lenses in reducing astigmatism in patients undergoing cataract surgery by resident surgeons. They used the pre-op astigmatism and the post-operative cylinder as primary outcomes for this study. So the reduction on astigmatism for this study had a mean of 1.36 diopters. As a conclusion, toric IOLs are effective in reducing astigmatism in patients undergoing resident performed surgery. But to further validate this point, the other study on the right now studied resident cases versus consultant cases, and the primary outcome measures included post-operative spherical equivalent, residual cylinder, and visual acuity. And the results of this study showed that there was no significant difference in the outcomes of either of the groups. The only difference they actually pointed out was that resident cases actually lasted longer. So as for my case, I always ask myself what I can improve on for a better outcome for my patient. So since I had difficulty positioning the IOL, I think I have to minimize eye manipulation. This includes careful IOL positioning on axis. This is also to avoid post-operative corneal edema and inflammation. By doing this, I will be able to get at least a stable anterior segment post-operatively. And then this is something that we have been emphasizing from the beginning. I would suggest careful and complete removal of the OVDs to avoid rotation and misalignment post-op. And for me, as a beginning surgeon and for the residents, it is really best to utilize the wavefront aberrometer for pre-op planning and post-operative monitoring. Overall, this experience, though I had just a few cases and it's very limited, will really be of good use in my practice in the future. It did not just help me gain valuable experiences, but it really helped me build my confidence as well. So again, this is why it's really best to learn the technique during residency, especially that not a lot of trainees get the same opportunity. As for the Alcon Impact Program, I think this program is really sustainable. It is both beneficial for residents and young consultants who want to take their skills further. This is also a program that will make surgeons realize that the procedure is doable and that non-refractive surgeons can actually do it with the right amount of courage and confidence. In fact, my batchmates and I were very lucky that we are part of this program, and I really do hope that this program will get a wider reach so that more residents and more younger consultants and surgeons are trained in the future. That was my last slide, and thank you so much for listening and for your continued support for TMC ITV.
Thank you so much to all of our speakers and for their wonderful lectures. I'm pretty sure we're all a little bit more enlightened on the experience of placing a toric IOL for our cataract patients.
Despite all these learnings, I'm sure some of us still have few clarifications. To give clearer insight on some of these tips, we will be answering some of the questions you have sent through our YouTube channel.
Yes, we'd like to welcome back our three speakers to the floor as we start our short open forum for this episode of ITV. Welcome back, doctors. All right, so we'll just wait for the questions to load. Oh, okay, there it is. So for the first question, when planning surgery with a toric IOL, do you treat with the rule and against the rule astigmatism the same or differently? I think this question is for pre-op, not Kish, I think.
Okay, so that's a really great question. No? So, if I had a patient with against the rule astigmatism, I would be more aggressive in making sure that this patient gets a toric lens. Why? Because if you see an against the rule astigmatism in the biometry printout, for example, this patient had a one against the rule astigmatism, the actual corneal astigmatism will be higher just because there's still an additional against the rule astigmatism from the posterior cornea. So if you see a patient like that, I would highly encourage the patient to get a toric lens. But if a patient with rule astigmatism and the patient really doesn't have any funds to get that, then I would be more comfortable telling the patient, okay, it's okay if we don't treat it, but again, ideally you should have gotten a toric lens because with the rule astigmatism in time converts to an against the rule astigmatism as we age. So that gives me a little bit of leeway in managing these patients.
Thank you for answering that, Doc Kish.
Okay, so let's wait for the second question. All right. Okay, so this question is really addressed to Dr. Glenn Angeles and Dr. Denise. Okay, so please give tips to our audience on how to manage rotation of the toric IOL after removal. I think this is a very important point. Doc Glenn?
Hi. Yeah, after removal of the gel of the OVD.
I think after removal. Is that after removal of the gel? Can you flash again the question, please?
Oh, after gel removal. So actually, for me, I usually position the IOL, the markings on the axis. Probably a few because when you use the Alcon lens, it's easier to rotate clockwise. So I usually place it in a position wherein it's just a little off from the axis marking. So when I remove the gel and I remove the OVD underneath the IOL, usually the IOL just moves a bit clockwise. So it's easier to rotate it now. So usually it rotates clockwise by itself. It's not going to the other side. So I usually make it, I usually put it, is it my, yeah, so just right before the center.
Okay, thank you, Doc Glenn. How about Denise?
Yes, Doc. It's just actually the same with Doc Glenn. My cataract mentors would usually advise me to put it a little bit under rotated. So actually around 10 to 20 degrees under rotated, so that when I do the gel removal, if in case the IOL moves during OVD removal, it will move a little bit, but then when I take out the IA probe, it will be on axis afterwards. And then when removing the gel under the IOL, sometimes you can use uh, your second instrument or your chopper to lift the IOL just to avoid any unnecessary rotation.
Thank you for the tips.
Yes, it clarified a lot. Okay, so for the next question, is there a role in combining LRI with toric IOL implantation? If so, would you do them at the same time, or would you defer doing LRI for residual post-operative astigmatism? I think maybe for the intro up, maybe Dr. Glenn, would you best answer this question? Or
Uh, yes, personally, I don't have any experience on doing LRIs with toric implantation, so I'm really not familiar with this. Maybe Keisha can answer that.
yes, Doc Kish, can you shed some light on this question?
Okay, so I think we rarely combine LRI with toric implantation because it defeats the purpose of putting a toric lens, and you incise the cornea. So that's something that the cornea surgeon will not really do, and hopefully general ophthalmologist as well. So if you plan to do a toric IOL implantation, then it's really best to target and all of the astigmatism that you should be correcting. However, if there is residual astigmatism, then that's a time that you can consider adding an incisional type of surgery that can correct the residual. But you usually do this when the astigmatism is already stable. It's already stable. So probably you can do it 4 weeks or even between 1 to 3 months. But it's rarely done because, again, if you alter the shape of the cornea and you're not accurate about the result of your LRI, then it might compromise the outcome already achieved by your toric lens. So we in our institution, I think we've done a lot of LRIs, but on patients who couldn't afford the toric IOLs. So that's where our experience is.
Yes, agree, Doc Kish.
Yeah.
Thank you for that.
Okay, so yeah, so LRI is another option for if the patient cannot afford toric. Okay, so for the next question, it's for Doc Ganada. When do you decide to use a CTR, and what is the cutoff white to white? Right. Then
For the white to white, I think if it exceeds 11, it is already actually good to use a CTR, as we know that the standard size or length of our IOLs are usually within 11 to 13.
okay. Thank you,
Right.
then.
That's something to take note of
Remember, yes.
and to remember. Yes. Okay, so for the next question, what are the most common reasons for residual astigmatism after toric IOL implantation, and how can this be corrected post-operatively? I think any of the speakers can answer this question with their experiences. um,
Any
Denise, here
experience?
I can hear.
Um, well, for my, again, very limited cases, so we I actually had a little post-op residual astigmatism, so I actually didn't do much about it. We actually just monitored and checked for the manifest refraction, which was at around 0.50 cylinder for most of my patients.
Okay. Thank you for that. If any of the other speakers, Doc Kish or Doc Len, if you have any experiences or to shed light on this one as well.
Yeah, so if you do notice a posterior residual astigmatism, it's nice to do there are two things that you can do. First is you can dilate up the eye, and then as Denise explained earlier, you can check first the alignment of the lens. And if it indeed it has rotated, then go ahead and schedule the patient for an IOL rotation. So that you can maximize the lens inside the eye. The longer you wait, it's actually harder to rotate back because fibrosis will already set in. So it's nice to do the rotation when the eye has just been operated on. Also, if you have access to the eye trace, as Denise explained earlier, you can order this, and without dilating the patient, it will tell you how many degrees you can rotate your IOL to achieve or correct the residual astigmatism.
Okay. Thank you for those tips, Doc Kish and Denise. Yeah, that's very interesting, no, because I'm sure a lot of us might, if we do try the toric IOLs and this happens, at least we sort of know how to remedy it. Thank you.
Okay, for our next question, how do you manage cases where the patient has significant post-operative astigmatism or lens tilt? And what are the treatment options for these complications? So, any from our panel can answer based on your experience. So, have you had any experience on lens tilt or on Doc Glenn?
Personally, I haven't experienced the lens tilt. Uh, I had one wherein I think it was the first part of the Alcon Impact program wherein I'm having a hard time removing cortical material, the subincisional cortical material for my patient. So there's residual astigmatism that time. Uh, After a few days, we just need to remove the um, retained cortical material, then just fix the axis properly. Then the patient's happy about that.
So the access is really important when it comes to toric
Yeah.
IOL, right? So do you have any tolerance, like how many degrees can you tolerate the lens being off axis? Keisha?
Yes. So if the lens rotates if it rotates 1 degree, okay, so it will reduce the effective correction to about 3%. So if you rotate the IOL off axis for 1 clock hour, which is 30 degrees, then that would effectively reduce the correction to 90%. So parang hindi ka na
Oh,
naglagay ng
Mm.
toric lens. So it's like putting a monofocal already. So I guess in terms of the acceptability, you should just remember that 1 degree is around 3%.
Yeah, so it's very, I mean, it should be precise. That's why, yeah.
And also, it's more sensitive if your correction is higher. So if you implanted, let's say, a T4, T5, T6, then if it just moves a little bit off axis, then the effect would be much higher, or effect would be higher rather.
Okay. Thank you. So, okay.
Yes. So, so for our next question, it's for Doc Keisha. When implanting a toric IOL for an eye with against the rule astigmatism, would you overcorrect so that the post-op astigmatism becomes with the rule?
Yeah, this is a nice question because initially I also thought that it would be nice to leave a patient with a residual with the rule. But when I attended a lot of symposiums on cataract and refractive surgery, actually the recommendation now is to leave the astigmatism closest to zero, whether it's with the rule or against the rule. Okay, so when you calculate, the goal is to reduce it closest to zero. So it's not anymore about if it's against the rule or with the rule.
Noted, Doc. Yeah. So at least, yeah, we know that it should be closest to zero. Okay. Thank you. Right.
Okay, so for our next question, how helpful is the eye trace on your post-op surprises, and how long do you wait till you make adjustments? So, any experience on eye trace from our panel? I think Keisha
I
has
think,
more
yeah,
experience on
she mentioned, yes, and she mentioned about it already. But yes.
Yeah. So for the eye trace, it's very important before you do order the test because it can be expensive for the patients. You verify the refraction. Don't rely on your automated refraction. So you do a manifest refraction. See if really the astigmatism is significant to the visual outcome. So yun yung first. That's the first thing. The next thing that you do is you have to check first if the tear film is stable. So don't order the test. Don't do anything first surgically. Check if the tear film is unstable, which can contribute to a false astigmatism in your manifest refraction. So that's also one thing that you should do. And then if you've already verified that the patient doesn't have dry eye, the significant is really astigmatism to the manifest refraction, to the visual outcome, that's the time that you order the eye trace. So it's nice to order this again for patients who you don't want to hassle undergoing dilation. So you can send them to the LASIK center, and then you just indicate in your request that this patient has had previous toric IOL implantation, so the nurses will know that they should give you that display. And then um, it's not really about the length of time before you order. It's really just seeing these two things. If the tear film was stable and the cylinder is really contributing to the visual outcome or deteriorating the visual outcome.
So for patients with severe dry eyes, you have to wait it out. You
Yes, you
have
have to
to.
treat first because whatever cylinder you get there, it will be off. And if you order the eye trace, the values that you get there will also be inaccurate. So sayang lang yung exam. So you really have to treat the ocular surface first because the accuracy of the eye trace is highly dependent on a good ocular surface.
But it's not totally a contraindication for IOL implantation.
The ocular surface disorder.
Yeah.
For toric lenses, highly ideal if you can treat the ocular surface and treat dry eye first. Because again, the key values that you will get from your biometry machines might not be accurate. And when you compute for your IOL, your toric IOLs, you might be implanting at the wrong axis or implanting the wrong cylindrical power correction. Baka you let's say overcorrect or plant in an axis that's totally off from what the patient really needs. So especially if this patient has an oblique astigmatism.
Okay. Thank you, Keisha, for sharing your thoughts.
Yeah, so very, it should be with
Yes.
the patients and it should be maximized actually. Yeah, her pre-op.
That's true. Okay, so
Okay,
another
so
go Pia.
oh, it's okay. So thank you, Doc. So for the next question, is there a need to repeat biometry for those with significant dry eye, even with the use of the pentacam? So I think Doc Kish already sort of touched on this um, topic of dry eyes, that we have to control it. Yes.
Yeah. So among your ocular biometry machines, the Pentacam actually is the least affected by ocular surface dryness. So if you have a very busy patient and this patient really cannot come back, then if the patient has mild to moderate dry eye, then yes, you can do away with not repeating it, I guess. But if you really want to optimize your outcomes and see for yourself if it changes, then you can order. I've had some patients already with severe dry eye, and this is seen in refractive patients. When we do a repeat pentacam, some of the values actually change. So, for example, the axis of your steep and your flat areas actually change sometimes for patients who have really severe ocular surface problems. So that's the time that I will really repeat the pentacam printout. But again, if you compare an IOL master and a pentacam, um, the pentacam will be a little bit insensitive to the patient's dryness, and what you get there you can actually already place in your calculator because it's not a
Okay, so when using
yeah.
okay, Doc. So when using the pentacam, you can have a little bit more of a leeway in terms of the dry eye situation of the patient. Okay, that's
Because
good to know. Okay.
Okay, so we have more questions coming. Okay, to all, can you trust auto-refraction post-toric IOL implantation? So I guess this is for everyone.
Yes. And I think
So
they've also touched on this.
yeah. Okay, then let's start with the
Yes,
youngest.
for most of my patients, I did auto-refraction. It's good to use both, I think, both manual and auto-refraction just to counter-check. But from my patients, I can usually see naman from the results of the auto-refraction, it's usually consistent for most.
Doc Glenn?
Actually, same with Denise. Most of my patients, when I do auto refraction, I also check with manifest. So far naman, most of my patients have low residual astigmatism or none after using toric IOLs, and most of the patients are actually happy about the results.
Yeah, so for the automated refractor, if you check the axis result there, it's actually a good clue for you already because usually it will follow the axis of implantation. So, for example, if you have a residual astigmatism and this patient's axis, what in the printout revealed 75 axis of the cylinder, when you dilate the patient, it will actually be close to 75. So it's a nice way to check without ordering all these fancy tools. You can still use your AR for that.
Okay, I think that was the last question for tonight. So, what a fruitful discussion. On behalf of all of us here at the Medical City Eye and Vision Institute, I would like to thank all of our speakers for their willingness to explore these new IOLs and for their kindness in sharing their insights.
Yes, indeed. So this has been such a wonderful beginning to kickstart our events for this 2023. Apart from this, we have got a few more ITV episodes in the works and even more live events to look forward to this 2023.
To tell you more about these special events and the things to watch out for this coming year, let us welcome our second year resident, Dr. Rexy Piad, for the ITV Bulletin.
So while waiting for apologies for the delay due to some technical difficulties.
Okay. So while waiting for the PowerPoint to load again, we would like to thank Alcon, our sponsor for today's TMC ITV episode, and all participants for tuning in. We hope you'll find this series informative and relevant to your practice.
Yes, that's true. I learned a lot, especially even during the question and answer portion. No? So a lot of the questions were some questions that I would have also asked myself. And it was so nice to hear from Doc Keisha, Doc Glenn, and also from Denise.
Yeah, very practical tips actually, Pia, that we can apply on our practice.
Yes, that's true. Because like for even for me, doc, like when during residency, I wasn't really able to do a lot of Toric cases, and it was nice hearing, especially for example from Denise as well, her post-operative experiences. Because when I was only able to do I think one or two, and then so you can't really see the effects after. So it was really nice to see that one from her, and from also from Doc Len and Doc Kish as well.
Yeah, it's very inspiring actually to see that we have young surgeons trying on new IOLs. So that means anyone can actually do it.
Yes, and they really seem to know what they're doing, because when we ask the questions, it's like they can explain it all very in basic terms. So I got to really understand it very well.
Okay.
All right. So maybe we can hear from our sponsor from Alcon again, if there's anything we can get from Alcon.
Hello, good evening, everyone. My name is Rexel Pia, and I'm a second year resident at the Medical City. And let me welcome you to this year's first episode of TMC ITV once again. So it's 2023. We are ushering in more patients, new residents, brand new DPBOs, and of course, more exciting events to attend in the upcoming weeks. So listen in and what the world of ophthalmology has in store for all of us in the next coming months. So first up, we have the Association for Research in Vision and Ophthalmology Conference in New Orleans. The theme this year is the beauty of diversity in science and nature, which focuses on speaking to the mechanistic diversity and ocular disease. So unfortunately, the deadline for submission of abstracts is closed, and it's actually scheduled in the next few days. But registration is still open. So for those of you who are interested to learn more about this, it's not too late to register, book those tickets, and next, the attendance to the ARVO conference might be a little hard to cram, but it's not too late to attend this year's PAO mid-year convention. So for those of you looking for a sign on whether or not they should attend this year's PAO mid-year convention, this is it. This is your sign. The convention will be held this year in Clark, Pampanga, with a lot of exciting lectures and events. So I'll see you there. And one of those events would be the I Run for Fun 2023. All of those who have the urge to get off their slit lamps, get off their microscopes, and get moving, you can choose between a 3, 5, or 10-kilometer run. If running is not your thing, that's okay. Maybe it's cycling. You also have the option to do a 21-kilometer bike or cycle. So if you run for fun, now is your chance. For the first time since the pandemic, the Asia Pacific Association of Cataract and Refractive Surgeons will be back to the face 3-day program. The Packers Conference is now back, and this year it will be held at Suntec Singapore Convention and Exhibition Center. So the theme for this year, Nexus, connecting everyone and everything. If you're looking for familiar faces who are going to attend the event, our very own Dr. Victor Caparas will be presenting a paper during this event. Some of our consultants are joining in, and our senior residents will also be in attendance. So don't miss out. Grab that chance, catch that lecture live, join in on this event on June 8 to 10. Registration is still open, and here are some important things to remember. The 10th World Glaucoma Congress will be on June 28 to July 1, 2023 in Rome, Italy. Late abstract submissions is open until April 26, 2023, so you actually have around 6 days to get those papers in. Registration is still open. Another conference is the APTOS, or Asia Pacific Teleophthalmology Society and Symposium. So this conference aims to bring together different professionals to form an alliance that promotes communication, exchange, and collaboration in teleophthalmology. So this is something very appropriate and very interesting given the post-pandemic times. So if you want to join in, you want to learn more about this, it's in December 2 to 3 in Thailand. Abstract submissions, hotel reservations, everything is still open. So register to attend. So here's some exciting news out there. For this year, we will be having our PAO Annual Congress in conjunction with the 6th ASEAN Ophthalmology Society Congress. So what an exciting event, since we will be joined not just by our colleagues here in the country, but also all over Asia. Registration and abstract submissions will be open this month. I'm sure not just me, but a lot of us are waiting for more details about this event. So everyone tune in. And last but most definitely not least, for the first time since the pandemic started, we will be having our very own face-to-face postgraduate conference to look forward to this July 29, 2023. Our conference is entitled The Next Big Thing, Training the Next Generation of Cataract Surgeons. There are a lot of new innovations that lead us to better treatment outcomes and become better cataract surgeons. So what an apt title and what an apt topic to discuss. So more details will be released very soon. As early as now, everyone, save the date. So mark your calendars, place it on your phones, tell your secretaries our conference will be held on July 29, 2023. So that concludes our segment for the Opta Bulletin. Everything you need to know today about the events to come in the next few months. So again, on behalf of the TMC Eye and Business Institute, we'd like to thank you for attending this episode of IT. We hope you join us again for our next episode. So thank you very much, and I hope you all have a very good night. Thank you.
Wow, thank you so much, Rexy, for the heads up for all those events. You made us all so excited for many things headed our way. So don't forget to save the date, and we hope to see you there. More details will be coming in these next few months.
Until then, this has been Dr. Aileen Saunar.
And this has been Dr. Pia Texon Diaz signing off as your moderators for this episode of ITV.
Thank you all, and good evening.
Thank you.